much more promising.
Right.
All right. Excellent. Thanks, Amy.
No worries, guys. Thanks. So as Glenn said, just going to go through a review of some videos of iStent inject and some of the situations that occur regularly with iStent surgery, and just how to potentially manage those or minimise them occurring. So the main things we're going to really look at are managing heme or hemorrhage, so blood in the anterior chamber, an under-implanted stent and how to optimise that and seat it nicely, trocar bias and how to avoid it, having a loose stent in the anterior chamber and rethreading that, and also just how you try to position two iStents really nicely 2 clock hours apart. So blood in the anterior chamber or heme, we always say it's a good sign if you see a little bit of blood when you put the iStent in, because it means you're in the right place. But it can also interfere with our view of the iStents and the operation in general. So the first thing is really to maintain a firm anterior chamber when you're going to try to keep the blood at bay. So you want to fill the anterior chamber across from the angle and fill the anterior chamber right up until it's the viscoelastic is egressing or coming out of the incision. And we all know you need to use a cohesive viscoelastic. That's just going to help deepen the anterior chamber and hold it nice and firm and try to keep the pressure nice and high in the eye so that the blood doesn't reflux out of the trabecular meshwork. Now, one little trick that can sometimes work is sometimes if a surgeon uses a duovisc, so a viscoelastic, so a cohesive and a dispersive viscoelastic. Sometimes just once you've filled the anterior chamber with, say, your Provisc or your cohesive, you can put a little bubble or a little burst of visco, so a dispersive, at the lip of the wound. And it sort of spreads out and acts as a tamponade to prevent that viscoelastic from burping out of the eye and holds that anterior chamber nice and firm. So sort of, as we said, the heme in the eye occurs more so when your anterior chamber becomes soft. So, and the eye softens generally due to 2 main reasons. Either the cornea is being compressed with the prism, so it's heavy-handed surgeon, or they're really pressing in the eye with the prism, or they're leaning on the lip of the wound, the main incision, and the viscoelastic's coming out of that incision. So you really need to be aware of floating the prism on the eye and trying not to lean on the wound too much. So if the blood does come out of the trabecular meshwork and impedes your view, you really want to go in with the viscoelastic and gently blow that blood away from the area that you want to implant the device. So make sure you've got your prism on the eye when you go in with viscoelastic to blow that blood away. And sometimes if the blood is too severe and it's just all becoming murky and mixing in with that viscoelastic, you might actually need to go in with an IA and suck out all the viscoelastic and start again and fill up the anterior chamber once again. So this is just a simple video of some blood starting to spread across and get in the way of the second stent. There'll be other videos that have images of heme in the eye, which I'll show you, but the eye's sort of softening there and the blood's running right over to the stent. And it's good to go in, like I said, with a viscoelastic. But one thing to be aware of is make sure they prime the visco before, because sometimes you just introduce bubbles into the way with the viscoelastic and that can cause more of an issue. This is dealt with nicely. But if they are going to use another viscoelastic, make sure it's primed first so there's no bubbles getting in the way. So I'll show you some more videos like that later on. There's a lot of other images with heme, and we'll come to those. But I'll speak about underimplantation, and this is very common. So an underimplanted stent can be seated correctly using a number of different techniques. I tend to tell my surgeons lots of different ways that they can do it, and they'll find what they're most comfortable with or what suits each situation best for them. So first you can place a trocar into the iStent, so into the eyelet of the iStent, and fire or hammer that stent in again if you have some remaining fires on your device. You can use the edge of the insertion sleeve to push the stent into place, just to nudge it in. You can use a viscoelastic cannula, which works very nicely with the G2W, having that wide flange. Or you can use some sort of second instrument, such as a Sinskey hook, or the sheathed tip of the device. And I'll show you a video of that. It's not my favourite, but there's a lot of different ways they can seat a stent correctly. So this is just a nice example of using, I'll just jump a bit until I centre it. There we go. Of using the third fire to seat the stent really nicely. So fire the first stent, and it's a little bit proud. It's not sitting properly. You leave it alone. And you go and you fire your second stent. And then just coming back to that first stent, it's just a little bit proud. You can see a little bit of the body of the stent there. It's a little bit loose. So put the trocar back in the centre and fire it home. And they're seated really nicely there. So you guys have all seen this in our training, just how to adjust a stent if it's a little bit proud with the edge of the insertion tube. So as you come away, it's a little bit angulated or not quite flush with the TM. What you want to do is just sink your trocar in beside the stent and just send it home with the edge of the insertion tube. There's a quick example of that in another video later on. It's hard to capture, but it's a really nice way of seating a stent, and I encourage that. Okay, can you still hear me talking? I just muted the video. So let's jump a little bit. Oh, sorry. So first stent goes in. Nice and controlled. And that second stent is in nicely. But what they do is go in and with a viscoelastic cannula, it's nice and flat. And I think they're seated really nicely. Well, actually that one might not be. And just push it home with the viscoelastic cannula. And secure it nicely there. It's a nice flat platform. But one thing that could make this video a whole lot easier and better is the magnification. So we can see the whole eye and the eyelashes and everything else apart from all around here. So magnification is really key. You need to be able to see the target that you're aiming for. And I would really impress that upon a number of surgeons to mag up so they can actually see the TM. So this is, like I said before, probably not my favourite way. I think this Dr. fiddles a little bit with the, it's a tricky case actually. They use the sheath sleeve to push the stents home. But in the process, because it's not flat, they actually knock the stent free by using that. So I can give it as an option, but I don't encourage my surgeons to use that. I prefer using the edge of the insertion tube or the trocar or a viscoelastic cannula. You'll see in a moment, he's sheathed the device, and here he pushes it, it actually pushes it free and knocks it out. It's just not fine enough. But one thing that does really nicely here, and we'll show some other videos and examples of it, is he actually rethreads that loose stent. knocks it around into the angles so it's facing the correct way. And then he dimples and fires that in again. But you'll see in a moment, he sheaths the device again, the iStent again, and uses that tip. But it's just really slippery and it tends to knock that stent free again. And in this case, it's quite lucky that it does end up being seated well in the end. But I think it's more luck. I don't encourage the surgeons to use that device. Can you guys all hear me still?
Hey, I might just stop there and maybe ask if there's any questions, I guess, from those first two intraoperative complications, I guess, managing hemoglobin in the eye or under implantation. Does anyone have any questions? No, pretty clear. Okay, thanks, Amy.
Okay. Trocar bias and how to avoid it. So we all know about it. We speak about it in our training. You really want to be able to keep that stent nice and centered down the cylinder when you're firing the device. So staying perpendicular or at right angles to the trabecular meshwork is really important to minimise any of that bias. And I would really encourage my surgeons to just adjust their chair position so that their approach is really comfortable and they're not skewed. They don't feel like they're sort of twisting their hand back to put the stent in a correct place. It's also really important that they can always see that a V-slot window or the window in the trocar in their centre. So if the surgeon's in the eye and they can't see, I ask them to gently just rotate their wrist until we can actually see the window, because you really need to be able to see if that trocar is nice and centered before you fire. You also want to be piercing the trabecular meshwork with the trocar. So I sink the trocar into the TM and use it sort of as an anchor so that you can align the tube or the insertion tube around the trocar. So I anchor with the trocar first and then center the cylinder around that. And sort of to my first or second point, you don't want to separate the placement of the iStents too much if their approach becomes compromised. So we would ideally like stents a couple of clock hours apart, but if the surgeon is really pulling on the wound and at a skewed angle to the TM, they're not going to get a good delivery of the stent because there's going to be bias with that trocar if they're uncomfortable. Just be cognizant or aware of both. We talk about the horizontal bias, which we can see, but there's also sort of vertical bias, whereas the trocar could be sitting or running along the back cylinder of the device. And you can't really see that, but the surgeon can definitely do that if they're leaning on the wound or not at a really face-on approach to the trabecular meshwork. So I'll just, we know it, we've seen it in our training. What we're talking about with bias is when that trocar's off to one side and it slows that iStent down when it's fired in and it's under implanted. It can also be dragged back out with the device or the iStent device if it's not centered, and it can pull the stent back out with it when you pull away from the trabecular meshwork. So this is a bit of a view where there's a fairly strong dimple, and you can see there's no horizontal bias. You can see the trocar in the centre there really nicely. The magnification's great. But when they pull away, they sort of drag sideways and down. And you see it kind of jerks and pulls down and then across to the side. I'll just show you that last bit again. So see it's dragging down, it pops out, and then it drags across to the side there, and the stent comes back with it. So the bias is almost just as important as it is when you're firing as it is when you're coming back, because a lot of the times the stents can come back with you if you're not pulling away from the TM in the same direction. So I'll show you in a couple of other videos some more bias examples as well. And you've seen one of these already, but a loose iStent in the anterior chamber and needing to rethread it. And when you start training a surgeon, a lot of them are very concerned about this, that if it comes off the end, what do they do? First thing I always tell them is, don't panic. It's not going to disappear. The stent's so light, it's always going to stay suspended in that viscoelastic. But if you need to rethread it, sometimes it's a good idea to nudge it into the angle of the eye up above the TM. So it gives you some sort of resistance instead of trying to rethread in space, sort of floating in the middle of the viscoelastic. When the stent can be nudged against something up near Schwalbe's line, it just makes it a whole lot easier to orientate it in the right position. And the other thing to really ensure is you make sure that the flange is, and not the head of the stent, is facing you when you're rethreading. I had a surgeon tell me he was really excited. He managed to rethread the iStent in the eye, but he threaded it first with the head first and then the flange last. So when he went to fire it, it wouldn't go into the trabecular meshwork. And look, if it gets too difficult in the eye, if your view's impaired, you've got blood in your viscoelastic, it's blurry, the eye's softening, I tell a surgeon you don't need to rethread it necessarily in the eye. Go in with some very fine forceps, either ILM forceps for VR surgery or capsulorhexis. A lot of surgeons have nice fine capsulorhexis forceps these days if they're using like a 2.2, 2.4 millimeter incision with their cataract surgery. Most of the capsulorhexis forceps are nice and fine. And go across into the angle, pick up the iStent, remove it from the eye, and you can place it on the cornea, and they can rethread on the cornea where they can change the magnification and focus, and you've got like a stable environment to rethread, and it's much easier.
Amy, there was before you go on, there was a
Please.
question, I think, from Trang, it was probably from a couple of minutes ago, said, can you please explain more about, it says, don't separate, compromise.
Oh, okay, yeah, thanks, Trang. So what I mean by separating, placing the iStents too far apart. So when I say if you don't want to separate them, also put them too far apart, because what you can do is actually pull on the wound and compromise your vision. So you're going to, for the sake of placing two stents at 2 clock hours apart, you don't want to necessarily do that if you can't see correctly, if you're going to disadvantage yourself by having a poor view or not at a nice square angle to the trabecular meshwork.
So creating too much striae on the cornea by stretching the wound.
Does that make sense?
Yeah, okay, thank you, Amy.
That's okay, thanks. Okay. Anything else, Glenn? No, okay. All right. So rethreading, this animation makes it look simple. But I'll show you a few examples in the eye. So we've already seen one, and that surgeon knocked them around to the nice orientation. Sorry. That's fine. I'll show you the real thing. So this is a tough case for a number of reasons. They have a bit of bias, and the view really isn't good because you get some blood at the interface. And I'll show you. So blood smearing in the viscoelastic and the prism, so making it all a bit murky, a bit hazy to view. A couple of things here with the bias. The sleeve hasn't been drawn all the way back, so you can't really see the bridge, and it's pulling back at a different angle, so that stent has become loose. and the vision's going. They leave it alone and they go around to try to implant the second eye stent. With the eyes softening, you can see some striae in the cornea. And they're really leaning on that wound. I'm not sure if you can see there at the actual incision site. I'll go back a sec. They're leaning down on that wound. So the direction when they pull back is not nice and straight. And sort of, I don't know if you can sort of see pressing down on the globe, on the wound at the incision site. So the eye's softening because of that. It's a bit of a tough view. And you can't see the bias. If you can't see, they're probably not going to go in really nicely. And it's pulled back out because of the angle of approach is different to the angle of withdrawal. The surgeon does pretty well. They sort of readjusted themselves and they knock the stent around so it's in the correct orientation. And nicely rethread that first one and pick a new point on the trabecular meshwork to fire in again. And they're not really leaning on the wound as much anymore. And adjust the magnification, which is key. So you've got a good view. Thinks about it for a while. You can do it. And slowly comes back at the same angle. So really nicely reimplanted. So that's their third fire. And then they go back and I'll just adjust. And again, the view is not the best view, but the surgeon's doing really quite well. Again, you can see the striae sort of thighs softening. They're leaning on that wound again. And ideally, it would be good to refill the anterior chamber here, make the eye firmer, blow away some of the blood, because here they're trying to find a place of clear trabecular meshwork where there's no blood and they can see. And you can see they're right at the edge of the wound, pulling right across to one side. So they're not going to separate these stents very far apart because they can't get a clear view. They're pulling off to the side and that's sort of making the view drop out of view.
So ideally, Amy, come out of the eye, refill, blow away some of that blood, reposition, and then come back in.
Perfect, Glenn.
Yeah.
These are things not to do, which is good to see. And they do manage the situation nicely, but a firm eye, clear from blood, is going to give you a much easier approach and result. Okay.
Was that one of your cases?
Me?
Yeah.
I wouldn't. No way. Mine are all perfect, Glenn. No, actually, it's a nice compilation from a lot of different of my team members and even overseas as well. So no, that wasn't. But it's a great training video.
Yeah.
And this one has a little bit of everything as well. So it's hard to just show one particular area in each video, but this has everything. So you get some bias and you get the first stent being incomplete. And again, we're going to rethread. The view's good. Put it around for a little bit. Here we go. So nice light dimple. the fire, and it comes out. So it's dragged out. So nicely rethread and nudge sort of into the angle to rethread it. Okay, pick another spot. Take a little while to pick a spot. Touch the iris for good measure. I don't know if you saw that. Okay. So picked another clear spot, nice dimple, not leaning on the wound. Fire. And then come back, and that's nicely seated. Little blood refluxing again, nice sign. Move around a couple of clock hours and just twist that prism a little bit. And that's seated really nicely. What they do is to the edge of the insertion tube, just touched it there. I don't know if you saw. It's actually seated really nicely, so they don't really need to do much. But I always tell my surgeons as well, just to make sure, go in and clear away any blood so you can actually see and make sure the stents are nice and secure and they're seated nicely. So always maintain that view with that prism when you're blowing away the blood. So a nice example of controlled approach, even though it's a little bit difficult with the rethread. Perfect position. So trying to get 2 clock hours apart. A really nice trick, if you guys have access or have used the iPrism X, the little sort of Eiffel Tower, our disposable one, there's a nice little, we'll call them bunny ears, little guide on the prism that indicates the 2 clock hours apart, irrespective of the magnification level that you're at. And it's a really nice guide so surgeons can get an appreciation of how far apart 2 clock hours is. I always speak to my surgeons as well about not being afraid to twist the prism, spin it in their fingers to be able to see a new area of trabecular meshwork. And I do this with them a lot, especially when they're starting to learn the iStent or doing some gonioscopy viewing initially. Some surgeons will get a clear view of the TM and kind of freeze and think, if I move my hand at all, that view's never going to come back. But I encourage them to twist or spin the prism in their fingers just so they get a good view of all the meshwork or as much meshwork as they can. Again, approach is really important when you're trying to separate those stents for a couple of clock hours. So encourage a surgeon to adjust their chair or move it around so that their approach again is nice and perpendicular. And don't be scared to come out and refill the anterior chamber with viscoelastic if the eye starts to soften. The better your view, good magnification, the better chance you're going to have of nicely and clearly implanting those stents. So these are a little bit proud in the trabecular meshwork, these stents. Second. And for this first one, it's important with your first stent to sort of stay fairly square on, but try to push your first implantation around to the left as much as possible, or the right if you start with the right one first. So that's probably not quite 2 clock hours, and I think they're a little bit proud. You can sort of see some of the body on the stents there. But it's a quite straightforward, clear implantation. This one is nice. The angle is quite steep for that first iStent. They're not quite square on. They're going at almost like 45 degrees instead of 90. So that stent is a little bit proud, and that's what you'll find a little bit with the G2W in particular, with that wide flange. If you're on an angle, it's going to sort of not seat and be flush with the TM. So this is much more perpendicular approach with this stent. And I think he cuts the video a little bit because he pushes them there a little bit. That's the right stent there is much deeper, but it's good separation and it's a good wide view as well. So moving the prism around to see the second stent. So this is probably the last example I have for you. That it's really nice hyperpigmented TM, really clear scleral spur. And they've pushed the first stent off to the left really nicely, quite far around. And now they sort of twist the prism and to look over to the other side of the trabecular meshwork. They're using our iPrism S, gives a really wide 190-degree view. The magnification could be higher here. You know, the bigger the magnification, the easier it is to hit your target. The eye stays nice and firm. There's no striae. The blood is slowly egressing out of there, slowly sort of leaking out, and not really fast, which means the eye is nice and firm and maintained. And it just twists that prism nicely from side to side. It gives you a good idea of how you can turn that prism quite comfortably and maintain your view, but see further round. And there's good old bubbles in your viscoelastic, sometimes more troublesome than they're worth. Okay.